day 57 of our quarantine home lockdown, and our second of the speaker series for our 7th annual Symposium on GNE Myopathy. Today's guest speaker is Dr. Kelly Crowe, with whom NDF has had a relationship over the last few years, and she has been working on a very important and critical piece of what we need to understand with regards to gene therapy for our disease, and that is the lectin staining to identify biomarkers. In today's talk, we're going to learn about what biomarkers actually are, what the lectin staining does to identify candidate things. I'm going to learn right along with you, and then at the end of it, we will have a wrap up. So we ask that everyone put your questions as we go along in the chat boxes. Mute your phones, and it's best if you turn off your cameras so that we can save the power for Kelly. This, for those of you who think that you have friends or loved ones that may be interested in this conversation and would like to join live, please text them the link that we can post here in the comment section, Rachel, if you wouldn't mind doing that. But without further ado, I'd like to turn the presentation over to Dr. Kelly Crowe, who is a professor at Mount St. Joseph, and he used to be with Nationwide Children's Hospital, so we're very lucky to have her. Welcome, Kelly.
Thanks, Lolly, and I appreciate the opportunity to talk to you guys today. Like Lolly said, I am an assistant professor at Mount St. Joseph University in Cincinnati, Ohio, but my previous work was done at Nationwide Children's Hospital with Paul Martin, where I worked on gene therapy for GNE myopathy. And so now that I have my own lab, working on a biomarker for gene therapy is something that's really important to me, because having worked in gene therapy for GNEM, I know how critical it is that you have a biomarker so that you can actually visualize what's going on with a gene therapy. So this is what Lolly was telling you. I'm going to be talking to you about the work that my lab has done on looking for a biomarker and why a biomarker is so important for gene therapy for GNE myopathy. But overall, what I'm going to be talking to you about, first of all, is what actually changes in a cell in GNE myopathy. And because there are several cellular changes that we can actually use as a biomarker. And then I'm going to talk to you about some therapies that are being developed. I know that the Lex talked to you last week about CRISPR gene editing, and I'm talking to you this week about gene therapy, and then you'll have future talks about the glycan therapies. And so I want to kind of talk about those different therapeutic approaches. And finally, I want to talk to you about my work on looking for a biomarker specifically for gene therapy. So starting off, we're going to look at what cellular changes actually occur in GNE myopathy. So to familiarize with you the picture here, what we're looking at is a schematic of a cell. And so as you know, within a cell, you have an area called a nucleus in which the DNA is kept. And there's tons of DNA in there, but one functional unit of DNA is called a gene. And so one of the genes among all of the genes in the DNA is this GNE gene. And you could think of the GNE gene as being like a code that gets turned into a protein. So the GNE gene, just in a cell, is made into this GNE protein. And then the function of the GNE protein is to work with a lot of other proteins to make a sugar. And that sugar is sialic acid. So GNE protein typically makes a lot of this sialic acid, and then the sialic acid is typically used outside of the cell on these long sugar chains. And so sialic acid is usually the last sugar on a whole chain of sugars on proteins outside of the cell. In the case of GNE myopathy, as you know, there are several mutations that can occur in this GNE gene. And the GNE gene, when it's mutated, is still able to make a protein, but that protein is mutated. And so because that GNE protein's job is to make that sugar, that sialic acid, the mutated protein is less able to effectively make sialic acid. So as this protein is mutated, less sialic acid is made overall. And so because of that, if you look at the outside of a cell, in the case of a cell of a patient with GNE myopathy, you'll see that normally all of these sugar chains would have sialic acid on the very end, like we saw on the last slide. But in this case, because there's less sialic acid being made, and so less of that sugar is available, only some of those sugar chains will have sialic acid on the end of the sugar chain here. And so that's kind of a summary of the major cellular changes that are occurring in the case of GNE myopathy. So next I want to talk to you about how the different therapies that are being developed can address bringing the sialic acid back to the cell. So I'm going to touch on these three major therapies that are in development for GNE myopathy. So the first is if this GNE gene is mutated, you can work to actively correct that mutation, so fix the mutated gene. And we'll go over each of these in a second in more detail. But when you're actually correcting the mutation in the cell, then that is CRISPR gene editing. And that's what Dr. Leck was talking to you about last week. Another option is not to fix the mutated gene, but to bring in a new gene, and that is gene therapy. And you may have also heard it called the gene replacement therapy. Those are the same thing. A third option is to bypass the GNE gene and protein altogether and to replace the sugar itself. And so that is glycan therapy. And so these are three different promising approaches for trying to restore the sialic acid to its normal location. So starting off with CRISPR gene editing, which is what the Lecks were talking to you about last week. With CRISPR gene editing, CRISPR is a very exciting new technology, and CRISPR allows you to actually go in and change the affected piece of DNA. So if there's a small mutation in that GNE gene, then via CRISPR, you can go in and directly repair that mutation. So in this case, CRISPR is delivered into the cell through something like a virus. And CRISPR can go in and actually correct that small piece of DNA, and you would have a corrected GNE gene. So after CRISPR, a cell receives CRISPR, the GNE gene, after it's corrected, would make a corrected GNE protein. That protein would be able to make sialic acid, and so that would restore the pool of sialic acid to be put on those sugar chains outside the cell. So this is the basics behind CRISPR gene editing. Another approach, and this is the approach that is my background and the approach that I'll be talking to you more about today, is gene therapy. And in gene therapy, you again deliver something to the cell using a virus, but in this case, instead of delivering machinery to fix the mutated gene, in this case, you're just delivering a new copy of the gene that's unmutated. So in this case, you can use a virus to deliver that DNA into a cell. And so after effective gene therapy, you would still have a mutated GNE gene, but in addition, you would have another non-mutated GNE gene that would have been delivered via the gene therapy. And so this new GNE gene that's been delivered can now make the GNE protein, which can make sialic acid, and then that sialic acid can be put on sugar chains outside the cell. And the third strategy is to replace the sugar itself. So in this case, you aren't affecting the mutated GNE gene, you aren't affecting the mutated GNE protein, but instead you're directly delivering the sugar and bypassing the need to have that mutated or to have a GNE gene and GNE protein. So in this case, you're directly delivering a sugar, and that sugar can be put outside the cell. And so the NIH's work on MANNAC is an example of a glycan therapy because you're bypassing the need for the GNE protein to be essential for making that sugar. You're just delivering the sugar. So when you're comparing these three different approaches, with CRISPR gene editing, you are directly going to fix the mutation in the gene. With gene therapy, you are providing a new gene in addition to the mutated gene. And then in glycan therapy, you're not providing a new gene and you're not fixing the gene, but instead you're delivering the end product of what that gene is used to make, which in this case is the sugar. And so that glycan therapy is providing that sugar. But in terms of those three therapies, they differ in approach, but they also differ in how far they are along in development. So the furthest along in clinical development, so this is kind of the process of how a therapy moves from a basic research in a lab all the way to an FDA-approved drug that's available. The general approach is that it starts off in a lab doing basic research and discovery. Still in a lab, you undergo preclinical studies where you're testing logistics like dose. And then finally, it moves into clinical trials. So there are three different phases of those clinical trials, and that's being used to look at that therapy in humans and patients. And then from there, it can be approved by the FDA. So as you know, MANNAC, which is a glycan therapy, that third type that we talked about, MANNAC is the furthest along because MANNAC is actually in clinical trials. The other two that we talked about are gene therapy and then CRISPR gene editing. And as the Lex were telling you last week, gene replacement therapy or gene therapy is, both of those are in the lab at this point. We're still testing in the lab to try to get it right. But in terms of CRISPR versus gene therapy is probably further along. And so CRISPR is still in this basic research stage. Very few diseases, I guess in general, for various diseases, fewer are using CRISPR approaches because it's just a newer technology and we don't know as much about it yet, but it is very promising. Gene therapy is a bit further along in terms of this pipeline. So CRISPR is at the most basic stage right now, and then gene therapy, and then glycan therapy. But next I want to talk to you about some of the work that my lab has been doing in looking for biomarkers for gene therapy in particular. So the idea that once you have a gene therapy developed, it's really important to be able to visualize how well that gene therapy is working at the cellular level. And so that's what my lab focuses on. Starting off again with gene therapy. In gene therapy, like we discussed, you're trying to introduce that genetic material into the cell. And so in addition to a mutated gene, you would have a non-mutated gene that's able to effectively make a protein, and that protein can make sialic acid. And gene therapy is a very promising approach for what are called monogenic disorders. And in a monogenic disorder, there's one gene that's mutated and we know what it is. And that's the case in GNE myopathy. The major gene mutation is the GNE gene. And so when you know which gene is the problem, then you can deliver that gene and hopefully that can be an effective therapy. But the major struggle with gene therapy is the ability to get that DNA into the cell. Cells don't like to take up DNA. And so it's a huge challenge to try to get that DNA actually into a cell. And that's why we use things called vectors. You may have heard of vectors. Vector is basically a way to get that GNE gene into a cell. And what we commonly use are viruses, because viruses are specialized at getting into cells. Viruses reproduce themselves by effectively getting into cells. And so what we can do is take out we scoop out basically the inward part of the virus that contains the virus DNA. So remove that so you just have the shell of a virus, and then put the DNA that we want in there. In that case, that would be the GNE gene. So you can have just basically the outer shell of a virus with a GNE gene inside, and then that virus is able to deliver that DNA into a cell. And so vector, like a virus, is a really effective way for getting DNA into a cell. And in the history of gene therapy, a lot of different viruses have been tested. And by far, the best one that anyone's tested is called adeno-associated virus, or AAV. And AAV is because of its safety profile and because of how good it is at getting DNA into cells, AAV right now is the vector of choice for gene therapy. We'll talk in a minute about gene therapies that have worked really well in other neuromuscular diseases, and almost everything right now is using AAV. So AAV as a virus is non-pathogenic, meaning it doesn't cause any disease. So even if you were to get AAV with AAV DNA inside, it wouldn't make you sick. It wouldn't cause any problems. So that's one reason why AAV is really useful. Another reason is that it doesn't cause a strong immune response. So if you as a patient are receiving AAV, you want to make sure that your immune system doesn't strongly respond and cause a lot of inflammation. And so another reason why AAV is particularly good for gene therapy is because it's not very good at stimulating the immune system. So it can be used to deliver DNA to cells without causing a lot of inflammation. And so AAV is a particularly good tool for getting that DNA into cells, which is the major challenge of gene therapy. And AAV gene therapy in particular has been really promising in a lot of diseases. So there are good clinical trials going for Duchenne muscular dystrophy, as well as another muscle disease called myotubular myopathy. But the biggest success story, which you may be familiar with in terms of gene therapy for neuromuscular disease, is spinal muscular atrophy, or SMA. And because SMA is, again, a monogenic disease, there's one mutated gene, and researchers were able to develop a gene therapy to use AAV to deliver that gene into cells. And that made it all the way through the clinical trials process, and it was approved by the FDA. So Zolgensma is this drug that is a gene therapy for SMA. And so that's one reason why we're particularly excited about AAV gene therapy and working so hard to develop it, because it's been so promising for other neuromuscular diseases. But because gene therapy has gone through this clinical trial process for other diseases, that's one of the ways that we know some of the possible pitfalls, and we know some of the questions that we need to address right now. And one of those major questions for a gene therapy is how you can see at the cellular level that it's working. And that brings us to biomarkers. So biomarkers are ways to objectively measure what's happening during a disease and during a therapy. And so as you're giving a gene therapy, particularly because GNE myopathy is slowly progressing, it's very difficult to tell early on how well the therapy is working. And so a biomarker is really crucial for giving you that information and saying what percentage of the muscle fibers have been successfully treated by this gene therapy. It also gives us information about whether or not the therapy is working the way that we think. Because as you're giving a therapy, like I was talking about earlier, if you're replacing the gene, then you would expect that the protein would come back as well, the non-mutated protein, and that you should see sugar going onto the cell membrane. And so if your biomarker is showing that that process isn't working, then that's really important information for a gene therapy. But biomarkers are also really important because they tell you how many muscle fibers were treated, which is really key and critical for gene therapy for a neuromuscular disease. So I told you it's really hard to get DNA into cells, and so we use these specialized vectors in order to get that DNA into cells. And so it's really key to know how well that process has worked. How many muscle fibers have we actually been able to treat? And from there, we can figure out how much treatment a patient would need to receive. So how many viral particles would be needed in order to get the correct number of muscle fibers treated. And so it's only through a biomarker where you can actually visualize the fibers that have been treated that you can figure out what kind of a dose you would need. And so because of that, biomarkers are really critical for a gene therapy, and it's something that the FDA needs to see because they need to know for a given number of virus or for a given amount of virus, how many muscle fibers are treated. It's a key piece of information. And so what my lab's interested in is using a protein called the lectin to visualize which cells have been treated by a GNE gene therapy. And we'll talk more about lectins in a minute, but lectins are proteins that bind sugars, and some lectins bind sialic acid. And so if you put a fluorescent tag on that protein, then you can visualize which cells have been treated by a gene therapy. So over here, this is work coming out of Paul Martin's lab. And Paul Martin, in addition to working on gene therapy for GNE myopathy, has also worked on a gene therapy for Duchenne muscular dystrophy. And his gene therapy for Duchenne muscular dystrophy also involves treating with a gene therapy that would eventually cause a sugar to be made. And so because of that similarity in the treatment there, Dr. Martin was able to use a lectin, in this case this lectin was called WFA, to visualize which muscle fibers had been treated by the gene therapy. So you can see here a bunch of really small circles. So a circle here and a circle here. Each one of these circles is a single muscle cell. So this is a cross-section of a muscle. If you were to take a muscle and look at it this way, this is a cross-section of a muscle, and you're looking at all of these individual muscle fibers. Down here, this is a control. So it hasn't been treated with any gene therapy at all. So you can see that none of these cells are very bright green. So as he puts a lectin on there, none of those lectins are binding well because he hasn't treated with a gene therapy yet that brings back the sugar. You can see there are these numbers here on the left-hand side. Each one of these numbers represents an increasing dose of a viral gene therapy. So he's giving more and more viral particles that deliver a gene that eventually makes a sugar. And then he's staining with this lectin. And so when you get up to these higher doses, you can see these bright green circles. And each of these bright green circles are indicating that a cell has effectively been treated by a gene therapy. And so based on this lectin staining, you can visualize which fibers have been effectively treated by the gene therapy. And so, and you can see that that is going to change via dose. And this is the kind of study that we're looking at when we're thinking about developing a therapy for GNE myopathy, because this worked very well for Duchenne muscular dystrophy, and Dr. Paul Martin was able to use a lectin to visualize which fibers had received the therapy, which, like I said, is that really critical piece of figuring out what dose you eventually need. And so my lab is looking to develop something like this for GNE myopathy, so that when the viral particle delivers the GNE gene, that you'd be able to visualize which fibers have been effectively treated by seeing this bright staining here. So going back to lectins, like I told you, lectins are sugar binding proteins. And there's a subset of lectins that can reflect whether or not sialic acid is present. And so those are the lectins that we really focus on because they can tell you whether or not sialic acid is present or absent. And so some lectins do this by directly binding sialic acid. And we can put a bright fluorescent tag on that lectin so that when the lectin binds, it's nice and bright green, like what you saw in the last slide. So some lectins directly bind sialic acid, and other lectins actually will only bind when sialic acid is missing. So some lectins can reflect the presence of sialic acid, and then some lectins can actually reflect the absence of sialic acid. And so we're looking at both of these as options for seeing which fibers have been treated by a gene therapy. So after a gene therapy, if you're looking at a lectin that directly binds sialic acid, you would expect that that in GNE myopathy, that you would actually see a decrease in the staining, that you would see less of that green signal. And then if you delivered a gene therapy, that signal would be brought back, so it would be increased. If you have a lectin, however, that binds structures underlying sialic acid, so lower down on the sugar chain, and the lectin only binds when sialic acid is missing, then you would expect that in the case of GNE myopathy, that would actually be increased. So you can see here, this is a condition without GNE myopathy, and this is with GNE myopathy, and you can see that there's actually an increase in staining here, and that's because these lectins that can bind the underlying sugar chain that's only revealed when sialic acid is missing, the lectins are more able to bind here, and it gives you a brighter signal. So these are two different options of lectins that are able to reflect the presence or absence of sialic acid. But there are a lot of different types of lectins, and these lectins bind different specific structures. So all of these, let's see, these lectins here, these options, all bind sialic acid, but they bind subtly different structures. So there are different ways in which sialic acid binds the sugars underneath. Sometimes it binds in different conformations. And so these different lectins will only bind based on specific conformations and specific ways that sialic acid is bound to the underlying sugar. And there are also some options for those lectins that bind underlying sugar structures. And so as you can see, even though there are those simple categories of lectins, there are actually quite a bit of different lectins that bind slightly different things. And so what my lab's really focused on is trying to figure out which of these lectins would be the most suitable for a biomarker for GNE myopathy gene therapy. So we've been doing a lot of, there's no perfect experiment to address this question. And so we've been using a lot of different systems and a lot of different types of experiments to try to figure out which of these lectins is going to be the most useful. And I'm going to show you one of those experiments today. So in this first set of experiments, we'll be looking at a lectin that directly binds sialic acid. So in the case of GNE myopathy, you would expect that to be reduced. So if you have a non-GNE myopathy cell with sialic acid, you would expect to see a lot of green because of that lectin being able to bind the sialic acid. In this experiment, we treated the non-GNE myopathy cells with an enzyme called neuraminidase. And neuraminidase is an enzyme that removes sialic acid. So it chops all the sialic acid off of those sugar structures on a cell. So after neuraminidase treatment, when the sialic acid is removed, then the lectin shouldn't be able to bind anymore because it can only bind when sialic acid is present. And now I'm going to show you what that data looked like in these cells. So we use three different lectins. These lectins are called MAA, SNA, and SSA. And so in this top panel, these are the cells that have not yet been treated. And in the bottom panel, these cells have been treated with neuraminidase, which chops off the sialic acid. So what we were expecting is that in this top panel, you would see a strong green signal, and in the bottom panel, that signal would be decreased. And here, as you're looking at the top panel and compared to the bottom panel, if the MAA lectin does show a decrease in signal after sialic acid is removed. And so because of that, we think that MAA is a good candidate for a biomarker for this GNE gene therapy, because as you're removing sialic acid, that signal is decreased. And you're looking at different muscle fibers here. We did not see that same effect with SNA or SSA, two other lectins that we tested. We also did a very similar experiment, but in this case, we used lectins that bind the underlying sugar structures. So in a non-GNEM cell, where there's sialic acid present, you would expect that these lectins would not be able to bind and that you would not have a very green signal. Again, we treated with neuraminidase, which is an enzyme that removes those sialic acids. And in this case, you would expect that the lectin should be able to bind and that you would see a brighter green signal. So we're looking at a similar setup here. On the top panel, we have 3 different lectins that all bind those underlying sugar structures, PNA, VVA, and SBA. And the top, these are all untreated. And at the bottom, these have been treated with neuraminidase, which removes the sialic acid. And so we would expect to see an increase in the green signal after neuraminidase treatment. And in this case, PNA, VVA, and SBA all showed a strong increase in signal when that sialic acid was removed. And so all 3 of these are good candidates because they're showing that strong difference when the sialic acid level is changed. So again, as we're looking at this panel, and we're trying to figure out which lectin is the most promising for a biomarker. If you remember back to the figure I showed you from Paul Martin's lab, he was able to, for a different disease and a different gene therapy, find a lectin that could light up when a cell had been treated with a gene therapy. And we're trying to figure out which lectin is best able to do that specifically for GNE myopathy. And so based on that experiment, those 4 that I showed you, MAA, VVA, SBA, and PNA, are promising candidates because they show a really strong difference when sialic acid is removed. But that's certainly not the end of what we're doing. We're really excited to test those lectins in other models through our wonderful collaborators. And so we're working closely. One experiment that we're doing that's up next is that we are looking at GNE knockout cells. So this is a cell line that was developed by the Leck lab at Yale, and they have cells in which these cells don't have a GNE gene at all. And in that case, you would expect that they would not have high levels of sialic acid at all. In that case, what we're going to do is we're going to take those cells without a GNE gene, and we're going to treat them with a GNE gene, just like you would with a gene therapy, but we're looking in these cells. And so after you bring the GNE gene back and that restores sialic acid, we're going to stain with those lectins again and see which lectin is going to show the strongest increase in signal when sialic acid is brought back by delivering the GNE gene itself. So that's an experiment that we're really excited about. And we're also going to be looking at a zebrafish model of GNE myopathy that was developed by Stella Matrani-Rosenbaum's lab at Hadassah. And we're very excited to also test our lectins in that system. And also, as you are likely aware, the Leck lab has a GNE myopathy biobank, and I know that many of you were able to contribute skin biopsies to that. And that's also something that we're using to try to test these different lectins and see which would be the best as a biomarker for GNE gene therapy. Like I said, there's no perfect one experiment that can give that answer, and that's why we're testing all of these different types of systems to try to get at that question of which is the most promising lectin to be used as a biomarker for GNE gene therapy. So in terms of acknowledgments, first and foremost, I'd like to thank the patient community. You all are the reason why we do what we do, and your support and your contribution in terms of samples has been the only reason that we can do what we do. I'd also like to thank the members of my lab who actually did this work, notably Christy Sattler and Bree Goins, and they did a lot of the work that you saw today. A huge thanks to our collaborators, particularly the LEC lab, who has the GNE Myopathy biobank that has been an invaluable resource for our work, and I know the work of many other labs, and they've been wonderful in sharing samples and providing help and collaborating. Also, the Noah Wise Leaders Lab at Ohio State and Paul Martin's lab at Nationwide Children's, also great collaborators of mine. And then I'd also huge thanks to the NDF for funding this work and for putting together the speaker series. This has the NDF has done fantastic work in supporting scientists and bringing new scientists into the GNE myopathy fold, and I know that Lolly works tirelessly to and is always available to help scientists and help try to break through any barriers and take down red tape to get us what we need. And she's been a tireless advocate. So thank you all for listening. And I'm going to, first of all, key takeaways: critical to find a biomarker to assess GNE gene therapy. We're looking at several lectins that seem like they're promising biomarkers, but we're going to be testing them in different systems to try to narrow that down further. And I would be happy to take any questions.
Thanks, Kelly. And come back on able to for some reason. But maybe when Rachel, you can do something on your end. I don't know if anyone can see me, but Kelly, I really appreciate that wonderful, very easy to understand presentation, and you're getting a lot of compliments in not only the comment section, but also people who are texting me and telling me that. We have a lot of questions for you, but I just wanted to wrap this up by saying that, you know, for those of you, the key takeaways that she just reiterated for us are, in fact, I hope you understand why finding a reliable biomarker is critical for the steps towards gene therapy. This is a question that at NDF we're faced with almost daily. Why is it taking so long? What's going on? When can we just dose human beings? And I hope that these series of speakers will be able to explain not only the steps required in order for us to be sure that what we apply to a human being is actually not only safe but efficacious and it's going to work, but also how each other's work dovetails, so that the work that Kelly does and why she references Marianne, the NIH, or the LEC lab at Yale, or Dr. Martin, so that you can begin to take these sort of various glimpses of what's happening and eventually put them together in a mosaic that will begin to make sense for all of you. So I'm going to start with the questions in no particular order. The last one to come in was, and again, you're getting a lot of talks. Angela Leck has a question. Do pathogenic mutations in the domain show different patterns of lectin staining?
Yeah, that's, sorry, I hope that you can still hear me here. Looks like you're.
I can hear you.
Yeah, okay. So in terms of, as you know, not every GNE myopathy patient has the same mutation. The GNE gene is a large gene, and there are different places in which that mutation can happen. And so one of the things that we're really hoping to address in future experiments and using the biobank from the LEC lab that has these samples from patients with different mutation is making sure that a lectin that we select doesn't just work for one mutation, but it's going to work for different patients with different mutations. And so that's something that we're definitely keeping in mind as we're moving forward, is making sure that a lectin is going to reflect changes in patients with any kind of mutation in GNE in the different places.
Thank you. I hope that answers the question. Another question, and this is something that people seem to be confused about and constantly ask us, is, and I hope you could shed some light on it in Buddha's context, is first of all, they're complimenting the great, inspiring, very understandable presentation once again, but they're asking, is this a one-time treatment, or this is Stephanie is asking this question, one-time gene replacement be one-time treatment, or would this need multiple treatments? So if you could shed some light on that within the broader context.
Yeah, that's a great question, and the really fantastic thing about gene therapy is that it is a one-time treatment. So the thing with gene therapy is that muscle cells normally don't actively divide all the time. Normally, once you have an adult muscle cell, then it sticks around for a long time. And so as you're delivering a gene therapy and that gene therapy actually gets into a cell, then that gene sticks around. Once it's in a cell, it sticks around for a long time and can continue to make GNE protein. And that's also one of the reasons why we have to be really sure that a gene therapy is working well before we deliver it, because you really only do get one shot at a gene therapy. And if you're going to deliver something, you want to make sure that it's going to be a gene therapy that works.
So sometimes taking a little longer is actually the shorter, better path to full recovery or any kind of recovery. Another question, thank you for that, is from Roberta, who says, will this method be available in all genetic mutations? She references the LEC talk from last week, and this actually, we got some follow-up questions from last week, is we learned that she says gene editing therapy will work for some mutations, I suppose suggesting that they may not work for all mutations. Can you shed some light on that for us?
Yeah, so gene editing has to be very specific to each mutation, because in gene editing, you're actually going in and correcting each individual mutation. But in the case of gene replacement, if you remember the figure where I was showing the gene editing versus gene replacement, in gene replacement, you're not doing anything to the mutated gene. You're delivering a corrected copy of the gene into the cell. And so that would not be mutation specific. Gene replacement would theoretically work for any mutation, because regardless of what the mutation is, you're delivering a new unmutated copy.
I see. And another question that occurs to me is are viruses the only vectors that can be considered for gene therapy for this disease?
Yeah,
we talk about that a lot. AAVs,
yeah, I talked about different vectors and why AAV is the most promising vector right now. And there's a lot of research being done more broadly in the gene therapy field, looking to develop new vectors. But the reason why we're so excited about AAV in particular is because right now AAV is looking the best for being able to move through clinical trials. And so in the future, I really hope that they're looking at things like, you may have heard about nanoparticles or other ways to deliver genes. And I'm really excited about that work developing. But right now, it's really important that we can choose the vector that is showing the most promise and moving effectively through clinical trials right now. And AAV is a great vector because of how safe and effective it's been shown to be.
I see. So thank you for that. Tammy Hardman has a question. When will the experiment with the knockout cells with different lectin staining be complete with results? 1 year, 2 years approximately? She wants to know.
That experiment in particular that I was talking about, where we're delivering the GNE gene to those GNE knockout cells, we're hoping that timeline will be shorter than a year. We're hoping, obviously unfortunately there are some restrictions on how research can be done and how buildings can be accessed right now due to the pandemic. But I am optimistic that that'll be done in the next couple of months.
Right. Well, that's very good, very hopeful. Thank you. Another question is from Dr. Leck. Are lectin assays amenable to quantification via flow symmetry based approaches, maybe more sensitive?
Yeah, that's a great question. So I was talking about lectin staining, where you're taking a cell or a muscle biopsy and you're putting the lectin directly on there and able to visualize where that lectin is. But another approach is called flow cytometry, where you break up the cells and you put them through a machine that sorts them based on whether or not the lectins can bind. But the reason why we're focused on, and flow cytometry is more sensitive as an approach, but the reason why we're so focused on staining in particular is because as you're doing a gene therapy for a muscle disease in particular, it becomes really important to know, to be able to visualize kind of which fibers are treated and which pattern the fibers are treated in. And so that can be really helpful to do the staining so that you can actually visually see the patterns of which cells have been treated. But flow cytometry would be another approach that could potentially be used.
Yes. And yeah, very informative answers. And then the final question is, are there any other therapies than the 3 that we've discussed so far?
Yeah, so the exciting thing is that even as these 3 therapies are that I discussed are being developed, there are other labs working on therapies that are completely different and using very different mechanisms to try to get at that same question. So I know that that there's a lab working on. So Dr. Noah Weisleiter's lab is working on membrane repair and a protein that would help with the membrane repair of cells. And so there are different approaches that are, and there is another group working on growth factor signaling. So there are lots of different types of approaches, and the exciting part is that hopefully some of these approaches can be added together. So you could have, hopefully in the future, you could have both a gene therapy and another therapy in addition. And so that would ideally work better than one therapy in isolation. So in terms of therapy development, in a lot of ways, it's really the more the merrier, because as many therapies as can get through, in some cases, you could receive more than one.
That's fascinating, and actually a topic that we should continue discussing at the Scientific Advisory Level Committee and figuring out how we can bring all of these together. Great presentation. Thank you so much to you, Kelly, and to everyone who listens in live and sends in questions. Obviously, this will be posted, as always, on the website within a week. And next week, we are fortunate to have Dr. Huizing from the NIH presenting a topic called NIH Research Studies for GNE Myopathy. She will not be taking questions about the trial per se, but we are going to be scheduling a talk specific to the MANAC trials coming up, and we're just now nailing down a date. It'll either be the May 29th or June 5th. We will get back to you about that. But again, really thank you so much for those of you who do make the time to interact with us by watching these live, and of course they're always available for download on demand. I hope that you give us your feedback on how these are working out for you, and while we will focus on the medical and scientific presentations first, we do have a whole series of wonderful topics that will be discussed that go beyond just science, but more into the psychology and practical aspects of being a patient, assistive devices, and things like that. So if you have any topics you'd like us to cover, please let us know, as we are going to be asking speakers and inviting them moving forward, and we plan to do this once a week for the remainder of the year. Thank you, everyone, again, and we will see you on the ethers online. Thank you. Goodbye.
Thank you all.